This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonia Deltredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This is kind of our annual roundup episode, right, Sonia?
Yes, and it's become annual because it took us like 9 months to get through 10 articles for some reason. I don't know what happened. Vacations, a lot of things that weren't articles that we produced. So I kind of had to, it was like a trip down memory lane to prepare for this episode. Barely remember this information.
Okay, I want to ask you, I want to say 3 words. I want you to repeat them back to me at the end of the roundup. Apple, penny, church.
I'm never, ever going to remember them. Readers or listeners, you can also see if you remember those 3 words and you can tell if you have dementia or not. And John, if you can draw a clock while I'm talking and make it 11:10 a.m., I'd appreciate it.
You know, I wonder the clock, though, like with like younger people, right? When like the handed clock is something that's like, what the heck is that?
I know, right? It's yeah. All right. Well, let's get started because we do have 10 articles to get through. So the first one in this roundup was episode 71, an article about buprenorphine and dental problems. It was titled Risk of Oral Health Problems in Adults with Opioid Use Disorder Treated with Transmucosal Buprenorphine. And this was really interesting because it is something my patients worry a lot about. So I was interested in the data on how buprenorphine really does affect the teeth. So in 2022, the FDA warned people about possible dental problems associated with the buprenorphine, like the sublingual or the buccal, not the injectable or the patches. It can cause caries, tooth decay, abscesses, infections, erosion, losing your fillings, in some cases, total tooth loss. And multiple cases were reported in individuals who had no prior history of dental problems. And the warning was based on safety concerns reported to the FDA in this sort of post-marketing period and some retrospective data. But what's hard to know, and I'm sure you've seen this too, John, like our patients with opioid use disorder, they have so many risk factors for poor oral health already. They don't go to the dentist. They have bad insurance. They don't brush or floss. They have other medical problems. They smoke tobacco, and they didn't get dental care as children often. They didn't get fluoride. They take other psychiatric medications that cause dry mouth. There's just a lot of issues, dental issues with these patients. There's some theory that they dull their dental pain with opioids, and so that makes it so they don't go to the dentist when other people might. So in general, it's challenging to determine if all these oral health problems are due to the buprenorphine or due to their pre-existing dental risk factors. And this paper tried to clarify that. So that's why I thought it was interesting. So this was a retrospective cohort study using a big insurance database with over 700,000 people in it with opioid use disorder. They looked at a cohort that had been exposed to buprenorphine with at least 3 prescriptions in 6 months, and then a matched cohort that had not been exposed to buprenorphine. And the outcome, and this was important, was ICD-10 codes for new oral health problems like tooth decay, cavities, oral infections, tooth loss, and then outpatient clinic visits. They followed patients for 5 years from the index date. And the thing is the dentists don't really use ICD-10 codes. Those are the medical codes. So your doctor had to note that you had a dental problem. The methods were good. You know, it was a big database, 700,000 people, pretty long follow-up for 5 years. But again, just because the dentists don't use those same codes, I think it probably missed a lot of patients. It only captured those who billed a dental problem through their medical insurance. Which, you know, and I spoke maybe incorrectly. You didn't have to tell your doctor you had dental problems, but you had to use your medical insurance to cover those dental problems. Or, you know, so it just probably missed a lot of people. I think I've only used my medical insurance once for a dental problem in my 50 years. So I think they were way undercounted. In terms of the results, the bottom line was that people who were prescribed buprenorphine displayed a 1.24 to 1.3 higher adjusted risk of acquiring new oral health problems at both the 1 and the 5-year follow-up, and that was statistically significant. The average time to developing that dental problem was about 1.3 years after the first buprenorphine prescription, and that was shorter than the control cohort who took about 1.5 years before any dental problems were noticed. And it was stable over time. It indicated that many problems take place early in treatment, and the dental effects appear to be kind of idiosyncratic rather than cumulative. So it wasn't that people who got more buprenorphine had more dental problems. So basically the results were statistically significant. The p-values were low. The confidence intervals were pretty tight. So they were good results. But again, I think the dental problems were undercounted. Overall, 9.2% of the patients had a new dental problem billed to medical insurance over the 5 years after their index date, compared to 8.4% of patients who did not have buprenorphine. So is this going to help me in patient care? That's a big question. And overall, I feel like this data does support the FDA's warning about potential oral health risk of buprenorphine. The study isn't going to lead me to stop recommending buprenorphine, but it actually did cause me to intensify my dental health counseling. So I really started nagging people more about getting regular dental care, recommending they rinse their mouth out with water after using buprenorphine. I tell them to wait at least an hour after their buprenorphine to brush their teeth, and I just tell it as part of my kind of counseling about the medication. So I don't think I've had any patients stop their buprenorphine because of dental problems, but definitely people are concerned about it. How about you? Did this article make a difference to you, John?
I feel like I still don't know how to feel about this. I do have patients now that have poor dentition and they kind of are requesting to discontinue their treatment because they don't want any kind of opioid agonist or partial agonist. So both methadone and buprenorphine have associations here. I think it's tough because I still think that I understand the warning. I still think there's a lot of confounding variables here. I think most patients with a substance use disorder are on state insurance. That's Medicaid. So they get medical coverage, not dental coverage, right? I feel like a lot of my groups in my recovery clinics, I feel like I'm always dealing with dental issues because they don't have a dentist and won't go to a dentist. So I still think that for me, this is a little bit out. I'm counseling people about it accordingly. I don't want people to use this as the sole reason for why they're going to discontinue treatment. And I do see at times it being utilized that way by some patients.
Well, and the solution is also you could switch people to injectable because this effect does not appear with injectable buprenorphine.
Definitely.
All right. Article 72.
Article 72, it's a symptom-triggered alcohol withdrawal management delivered over telemedicine. It's from Journal of Addiction Medicine from November and December of 2025. So the clinical question here was for adults with alcohol use disorder at risk for uncomplicated alcohol withdrawal, is symptom-triggered alcohol withdrawal management delivered via telehealth feasible, safe, and acceptable? And I think that, there's a massive need here for telehealth expansion. We love telehealth because it can allow access for resources to areas of the country that typically don't have access to certain clinics or are kind of more rural and centers that lack specialist presence or kind of treatment or detox centers. So I think it's a really interesting question. So the methods for this was a prospective single-arm feasibility study of 30 adults with alcohol use disorder and prior uncomplicated alcohol withdrawal. And so basically they did a 3-day telemedicine protocol utilizing daily video visits with symptom-triggered diazepam guided by telemedicine adapted CWA protocol. They did kind of a check-in daily, and then based upon your CWA scores, they would redo the frequency for several other check-ins throughout the day to kind of repeat scoring and determine appropriate treatment. The primary outcome was treatment retention and need for higher level of care. Secondary outcomes included withdrawal severity, medication use, adverse events, patient satisfaction, and 30-day alcohol use. When you look at the results, this program was very significantly positive. 93.3% completed the full 3-day withdrawal program. That significantly exceeded kind of their benchmark for feasibility. No participants required emergency department evaluation, hospitalization, or higher level of care. So everyone was pretty much safely treated at home, except for the ones that discontinued treatment. There's no seizures, DTs, hallucinosis, or serious medication-related adverse events. Most patients successfully completed withdrawal within 3 days using both relatively modest diazepam doses. And, the nice part about this is that the overwhelming majority of patients were linked to medications for alcohol use disorder. So it's all embedded, as opposed to like classically, I believe the last time I saw the number was about 10% of patients have access to and are treated with medication. So here is almost 90%, which is fantastic. Patient satisfaction scores with the telemedicine were very high, supporting acceptability of this treatment model. So kind of like my clinical bottom line here is that telemedicine-based symptom-triggered alcohol withdrawal management appears to be a very safe and viable option. I do hope that in the future we kind of expand this services and someone takes the reign here and kind of opens up this in more regions that don't have access to this. It's not ready to help me in patient care directly at the moment, but I think it is an interesting idea that, could potentially allow access to treatment, including linkage to medications for alcohol use disorder for a large portion of the population that currently don't have that access.
Yeah, it's a great proof of concept study. We get so anxious about alcohol withdrawal management because of the potential for DTs, seizures, even death if it gets bad. But most cases are uncomplicated. And with sort of frequent check-ins, you could totally do it at home.
Yeah. It's interesting. I'd be interested to see how this progresses to, kind of our current climate right now. It seems like it's interesting. We were kind of all forward with telemedicine, and I'm sure people are following the news right now about psychiatric telemedicine care and ramifications there legally. And it sounds like really kind of quite a bit of public backlash regarding the telemedicine only services provided there. So I'd be interested to see if there's a shift here a little bit culturally.
And you also need to merge it with an article you're going to talk about later, which was phenobarbital driven alcohol withdrawal. Like imagine if you got your single dose of phenobarb and then you go home and you get monitored over telemedicine, for 3 days.
Come on.
Sorry.
Spoiler alert. Come on, man.
But no, I'm merging the two articles. Like that would be so easy because there's always a worry about our patients going to be able to manage these symptom-triggered medications,
Yeah.
All right. Article 73. Sorry,
Yep.
I didn't mean to cut you off.
Go for it.
All right. We got it. It's late night already. We got to get on here. Article 73, long-term opioid use after a first prescription. So this was an article published in the Journal of Drug and Alcohol Dependence at the very end of 2024. So it's a little old now, but it wasn't so old when we presented it. And the official title is an updated view on the influence of initial opioid prescription characteristics on long-term opioid use among opioid-naive patients. It's a bit of a mouthful. So in 2016, as those of us who are in medicine know, the CDC released these guidelines regarding opioid prescribing, which included recommendations for like a safe total daily morphine equivalent, which is 90 morphine milliequivalents a day. And then they updated those guidelines in 2022 because it was recognized that long-term opioid prescribing was a risk factor for overdose. And the initial recommendations were aimed at reducing prescribing across the board. But then a lot of patients, it wasn't done very well. A lot of doctors sort of set arbitrary limits on people. A lot of patients were cut off from medication. A lot of people did suffer and turn to illicit opioids. So we did reduce prescribing, especially connected to surgeries and procedures, and many doctors have become hesitant to prescribe opioids. Also now with fentanyl coming up, prescription opioids really began to play less of a role in the landscape of opioid use disorder overall. So if you remember, 10 years ago, a lot of our patients would say their first opioid was a prescription, they got onto really high dose with prescriptions, and then they were cut off by their doctor, and then they turned to illicit drugs. And I don't see that story so much anymore, especially with younger people. They pretty much may have gotten a little bit of prescribed opioids, but usually they started just using illicit drugs recreationally, and that's how they developed opioid use disorder. So things have changed, and the question in this study is, in this new landscape, what is the risk of progressing to long-term opioid use after a single initial prescription, given that prescribing is down and the illicit drug supply now includes fentanyl? So are these opioid prescriptions as dangerous as they were in 2016? This was a retrospective insurance database study. It used a big sample again, 600,000 people all throughout the US. And these were opioid naive people, and they got an opioid prescription. What is the time to opioid discontinuation, meaning how long do they stay on the opioids? And what's the risk of transitioning to long-term opioid treatment, meaning greater than a year? And they looked at which of the initial prescriptions were risky, what type of opioid, what duration of initial prescription, what was their indication. So which prescriptions led or correlated with long-term opioid prescribing. They tried to control for all the things, all the socio-demographic factors that might influence opioid prescriptions. They tried to control for etiology of the pain. And the patients were followed until they discontinued opioids or left the database altogether. So just a big retrospective cohort study. In terms of validity, it was a valid trial. It had a very large size. It was very clinically relevant, I thought. And they did a great job comparing the 2022 outcomes to the 2016 outcomes. There was some limitations, though, inherent in prospective cohort studies and insurance database studies. Patients who got different kinds of opioid prescriptions weren't necessarily the same at baseline. Like, for instance, a patient who got 3 days of tramadol as an initial prescription likely has something different going on than some patient who got 30 days of OxyContin as an initial prescription. It's hard to compare those two people. So I think that does affect validity, but it was a good study. In terms of the results, they showed that in this current era of more conservative opioid prescribing, and the strongest factor in the likelihood of long-term opioid use was the number of days in the initial prescription. And that didn't surprise me. So people who got a longer initial script had higher risk of continuing opioids long term. In terms of specific numbers, if you want to know, about 5.05% of people who got an initial opioid prescription were still on opioids a year later. The likelihood of stopping your opioids was lower with higher days supply. So the number of days you got strongly influenced the likelihood that you would be continuing on the opioids long term. The risk started to rise about day 4. So up to day 3, it didn't really matter. But then starting about day 4 of opioids in the initial prescription, the risk of continuing long term would rise. It also was a higher risk if you received a long-acting opioid, and then the next highest risk was tramadol. People who received short-acting oxycodone had the lowest likelihood of continued opioid use at 1 year. Also, people with chronic non-cancer pain had the highest likelihood of continued opioid use, and that was about 7 points. So what was really interesting to me is that on average, actually, opioid prescribing didn't really change that much. Fewer people were initially prescribed opioids for extended periods. Before 2016, 15.5% of initial opioid prescriptions were for greater than 7 days, and now it's about 12%. Slightly fewer people continued opioids for at least a year. It was 5.05% of initial opioid prescriptions were continued for a year compared to 5.3% were continued for a year from before 2016. So, I feel like there's a lot of education and knowledge about opioid prescribing, but the total number actually didn't go down a lot. At the population level, fewer people are transitioning to long-term opioid use, and the rate of prescribing the initial opioids with a long sort of initial duration has gone down. But I don't know, it hasn't changed as much as I thought. So is this going to help me in patient care? I think so. I do have patients requesting opioid prescriptions. I treat chronic pain and acute pain with opioids. People request them in both indicated and non-indicated situations. And I often have patients asking me to extend the duration of their initial opioid prescription when the surgeon declines. That's a situation that makes me a little uncomfortable. So I don't know. I can't really make a risk-benefit decision using this study because it doesn't really talk about the benefits. That's a problem with all studies on opioids. If you're trying to do a risk-benefit analysis, it's very hard to study the benefits. All the studies do is point out the risks. But I think we shouldn't let our guard down regarding opioid prescribing. It's almost as dangerous as it was before. We should limit our prescriptions to 5 days or less and only extend them if we really need to. And I'll still use short-acting oxycodone and hydrocodone as my initial prescription if I have to choose. I'll avoid long-acting opioids. And tramadol weirdly seems to confer some excessive risk as well. So I've become a little more cautious with tramadol prescribing. Although, like we talked about in our full podcast, if you're have sort of a low-level chronic pain and you do need chronic opioids, a lot of people do choose tramadol because it has fewer side effects for a lot of patients than oxycodone maybe. So I don't know. What did you think of this study, John?
I think it's interesting kind of facts there. I mean, this is kind of common with other themes, right? That in terms of duration of prescribing, it is interesting. This is not the first trial where I've seen about tramadol being an outlier here. And I can't tell, is it really the tramadol? And I know that people say that people like it because it has that shotgun, kind of the serotonin effects as well, which you don't kind of get so much of the other opioids. Or is it just kind of like a safer, low-level opioid with less side effects, less opioid-induced constipation? I mean, people feel more functional because there's less sedation on it. I don't know. I've heard that argument too.
All right. Well, stay tuned. You ready for our next article?
Yeah. Episode 74, Rapid versus Standard Induction to Extended Release Buprenorphine. This is from JAMA Network Open from October of 2025. And I think this is an interesting question, right? So when you kind of look at the manufacturer initially for our extended release buprenorphine, you have to do an oral lead-in. Sometimes that can kind of be painful. Also, if you really follow the manufacturer, especially early on, many patients have to up-titrate their dose to that 16 milligram dose per the manufacturer as part of the lead-in, which always feels weird when you're kind of raising the dose to convert someone over onto a therapy where they're already successful. So the clinical question is, among adults with opioid use disorder, including those using fentanyl, is rapid induction to extended-release buprenorphine as safe and effective as standard 7-day induction? And so this was a multi-center, open-label RCT, including 729 adults with moderate to severe opioid use disorder. They are randomized 2-to-1 to rapid induction, which meant you got the same day injection after a single 4 milligram sublingual buprenorphine dose, which is like the devil's dose, right? I think that's the dose where you're likely to get precipitated withdrawal, not really capture symptoms. So it's kind of, it's like the number of the beast versus standard induction. That was 7 days of sublingual buprenorphine before injection. The primary outcome was treatment retention through the second extended release buprenorphine injection. So did you make it to your second shot? This was really interesting. The results show that retention through the second injection was actually much higher in the rapid induction group. So 66.4% versus 54.5%. And that was statistically significant. Even more interesting, among fentanyl positive participants, retention improved even more. So 62.8% versus 47.9%. So our group that's typically more difficult to capture and induce did better with the rapid induction. Retention through the third injection favored the rapid induction, 58.9 versus 51%. Time to treatment discontinuation favored the rapid induction, although that was not statistically significant. And rates of serious adverse events, opioid withdrawal events, and injection-related reactions were similar between groups. So clinical bottom line is the rapid induction to extended-release buprenorphine is safe and seems to improve treatment retention, particularly in our difficult-to start treatment subgroups of fentanyl-positive patients. So this is interesting. I will tell you, I've done this now in one patient, and one time out of one, it worked 100% of the time.
So they got a single dose and then got the shot.
Yeah. And I gave them this article to read before. I don't know if they actually read it, but I did give it to them when they were contemplating.
Well, I'm glad it worked. Well, and then we talk later about, more spoilers, direct-to-inject, where you just skip the test dose altogether. This is like an interim step between a full 7-day lead-in and no lead-in at all. All right, next article. So we're going to switch to methamphetamine. So this article is Contingency Management for Stimulant Use Disorder and Association with Mortality, a cohort study, published in the American Journal of Psychiatry, 2025, November. This was episode 75. So this article, it's a large retrospective cohort study examining whether contingency management reduces mortality among people with stimulant use disorder. As you might know, as everybody knows, stimulant-related deaths have risen sharply in the U.S., contributing to half of all overdose deaths in 2021. And contingency management is the most evidence-supported behavioral intervention for stimulant use disorder. And for those of you who don't know, contingency management is a therapy technique where you basically get prizes, and the prizes get better and better the longer you stay abstinent. So you might provide methamphetamine-free urine sample, and every week that you do that, you get a better and better prize. So it gives you a reward for doing the behavior that the therapy is trying to encourage. The U.S. Veterans Health Administration operates a really large contingency management program, multiple groups all over the country, and they have a standardized note template. So that allows them to compare their outcomes from one group to the other. And that's another problem with therapy techniques. They can be really dependent on the individual therapist. And so it's hard to get a really large cohort of patients to study a therapy technique. So this study, it looked at data from 138,280 adults with stimulant use disorder treated at the VA between 2018 and 2020. And those who received contingency management, up to just one session, they had to start a contingency management program. They were mapped to similar individuals who did not receive contingency management based on various demographics, comorbidities. And the primary outcome was all-cause mortality, so a nice, clean outcome. They also looked at psychiatric hospitalizations as an exploratory outcome because methamphetamine and stimulants in general can really induce psychosis. The results showed that there was a significantly lower mortality rate in the contingency management group. They had 4.8 deaths per 100,000 person days compared to 8.2 in the control group, so like a 41% reduction in mortality. Overdose deaths were fewer among the contingency management participants. Interestingly, a higher proportion of contingency management participants were hospitalized during follow-up. And hard to say why that is. It may reflect that they're just engaged with care. And so they also were engaged with coming into the hospital. They were seeing therapists, groups, doctors. It doesn't necessarily mean their health was worse. Overall, this is really strong real-world evidence that contingency management substantially reduces mortality among people with stimulant use disorder. There are just a lot of implementation barriers, though. There's stigma, there's regulatory hurdles, there's funding limitations. And these, maybe this article will help kind of overcome some of those barriers and convince society at large that contingency management is a good thing and support its adoption. I thought this was a really unique and interesting article. And we've been hoping we can offer some more contingency management services in our area, but there are just so many barriers. It's very hard to set it up, even though it seems like a simple concept.
Yeah. Yeah, I feel like we just keep talking about it. And I mean, I think California's got it, but the rest of us, I think we're just kind of struggling to make this work, although we know it works. And it's
That's a
interesting.
bit.
A patient today was describing to me about the recovery, how they're just missing something, and that, they've thought about doing something like going to the casino just to get that dopamine hit every so often that they're missing. I'm like, what you're describing is contingency management. It's like exactly
Yeah.
what they were describing.
I actually started an unofficial, totally funded by me contingency management program in my office where every time you show up for a visit, you get a prize. And I don't have funding to like have escalating prizes of increasing value because, as I said, this is funded personally. But
Mm.
people really love the little prizes, even though they're kind of goofy. And people get sad when it's a telemedicine visit and they don't get their prize. And sometimes people will ask if they could have the prize anyway, if they like stop by the office later and get it at the front desk.
That's funny.
Which I always say, of course you can. So I think it does give people a little boost. It's nice to have something nice when you come to the doctor instead of just it being sort of an annoying chore.
Yeah, it's awesome. Yeah, hopefully we'll do something with that at some point. Episode 76, extended release for sublingual buprenorphine during pregnancy from JAMA Internal Medicine, March 2026. So the question is, in pregnant patients with opioid use disorder, does weekly extended release buprenorphine improve maternal opioid abstinence or neonatal outcomes compared with sublingual? So this is an open label and a little background. I think many of us know that, this clinical question comes up all the time about like someone's on a depot injection and they become pregnant. What do you do? And there's some concerns, at least in animal models, about kind of the solvent that kind of makes the actuating agent present being teratogenetic, although it looks like the newer data doesn't support that whatsoever. So this is an open label RCT of 140 pregnant adults with opioid use disorder across 13 outpatient sites, compared weekly subcutaneous extended release buprenorphine with daily sublingual buprenorphine throughout pregnancy, and they followed people up to 12 months postpartum, including the baby. Primary outcome was illicit opioid abstinence during pregnancy with secondary maternal and neonatal outcomes. The results were extended release buprenorphine produced higher pregnancy abstinence, 82.5% versus 72.6%, very statistically significant. Postpartum abstinence rates were similar among groups. Serious maternal adverse events during pregnancy and postpartum were significantly lower in the extended release buprenorphine group. Women receiving extended release buprenorphine required less postpartum opioid pain medication, and lower postpartum anxiety scores were felt by those patients. Neonatal abstinence syndrome treatment rates and duration, including hospital length of stay and developmental outcomes of the infants up to 12 months, were similar between groups. So, it's interesting. This study shows that in pregnancy, actually, something we're not commonly doing, but extended release buprenorphine seems to reign supreme here. So kind of my clinical bottom line here is weekly extended release buprenorphine improves maternal opioid abstinence during pregnancy while maintaining kind of reduced neonatal abstinence scores, better neonatal outcomes than sublingual therapy, or at least equivocal neonatal outcomes. So it's making an attractive treatment alternative for the right patients. Very interesting, and hopefully something we can offer more routinely in the future.
I just really feel like I have yet to see a study that shows that injectable buprenorphine is worse. It's just like, it seems like such a great product. And I kind of wish I could get everybody onto it. It's so much safer and it's so, I don't say so much safer, but it's just like, it's so much more consistent. It's easier to manage. I don't know. It overcomes the big barrier I feel to buprenorphine. Like, I love prescribing buprenorphine. And I just feel the one thing I don't like about it is how dependent patients are on me and it. God forbid you run out, the pharmacy's closed, there's a blizzard, your doctor gets arrested and you don't have it. So, that happened in our area a few times. Like, and then the patients really suffer, and I hate that. And so these injectables really get around that problem. Like, if you get cut off for some reason, at least you don't suffer significant withdrawal. All right. Episode 77. This was a little different, but I really, really enjoyed. This is, I think, my favorite one of all these articles to prepare over these last 10. And this is the one on Epic's opioid risk score. The article is titled External Validation of Epic's Risk of Opioid Abuse and Overdose Model Among Primary Care Patients in 3 Health Systems. So a little bit of background. Many of us use Epic, and this was an external validation study of Epic's opioid risk score, which is a feature in Epic that you can turn on, and it tells you if a patient is high risk for developing an opioid use disorder or having an opioid overdose. And how this risk score is calculated is proprietary, so nobody knows except for Epic. but it's been used quite a lot and there isn't much external validation data. So St. Max's at our institution, we were offered this tool, but we declined it. We decided not to use it because of the lack of transparency about how the risk score was developed, as well as a few other flaws in the score I'll get into. The clinical question is about external validation of this score. So it was a prospective cohort study to externally validate Epic's opioid risk score in an outpatient primary care setting. They looked at 704,764 adult patients. It's a very large number who had a primary care encounter and did not already have an opioid use disorder diagnosis. They recorded the opioid risk score, and then they waited to see if the patients did have overdoses or develop opioid use disorder, and so they could test the accuracy of the model. So again, this is called external validation. They also evaluated the risk score's performance by calculating its sensitivity, specificity, positive predictive value, negative predictive value. They did some other evaluations of the model as well. And if you wanted all the math and all of those scores, I can refer you to the full podcast again, which was episode 77. So I'm going to point out now some weaknesses in this score itself. This was a very strong study of a very weak score. First one is that the score doesn't flag the highest risk group, which are people who already have opioid use disorder. And I can see that logically, maybe a computer engineer might say, why would you need to flag people who you already know have opioid use disorder? You already know they have it. Why do you need them flagged? But in a clinical setting, we don't really think that way. We're not interested in the narrow question of who will develop opioid use disorder for the first time. We're just interested in who's going to get in trouble with our prescription. Will this patient in front of me have problems with the opioids I'm about to prescribe? And if they don't get a risk score because they already have opioid use disorder, that gives us, the providers, a false sense of security. Number two, the outcome is pretty rare. So it is pretty rare to develop opioid use disorder. So achieving adequate sensitivity and positive predictive value for this risk score is kind of hard. They also couldn't look at other important opioid use disorder predictors because they're not really captured in structured EPIC data, things like housing status, history of incarceration, family history of opioid use disorder. They're just not consistently entered in the database. And then finally, EPIC provided only limited information about the development of their model. They provided like the threshold selection, sensitivity, and specificity, but we don't know what factors actually went into it. So it's hard for us to say exactly whether we think it's good or not. So those are the problems with the model, but not problems with the study. The people who did this study aren't the ones who developed this model. So what are the results? Most patients, 99.6% of patients in this study were low risk. 0.4% were classified as high risk by the risk score. So almost everybody was classified as low risk. Very few patients experienced an opioid use disorder diagnosis or an overdose in the 12 months following the initial index visit. It was 0.3%. with an N of 2,362 people. And remember, this study had hundreds of thousands of people in it. The model, and also this isn't everyone who's going to have an overdose. It's just people who are going to get opioid use disorder for the first time. The model correctly classified 185 of the 2,362 patients who experienced an event, giving it a sensitivity of 7.8%, which is really pathetic. It identified most of the patients who did not experience an event, giving it a specificity of 99.6%. So really good specificity, really low sensitivity. Very few patients who had that high score experienced an event, meaning the positive predictive value was 6.9%, very low. And many patients with a low score did not have an event, meaning the negative predictive value was very high. So basically, most of the patients who got a high opioid risk score did not have an opioid event. The false positive rate was super high. And if the intervention is just to provide some information and maybe give the patient information on opioid use disorder, that's fine. But if you use this score to withhold opioids from someone in pain, it's really not okay. The sensitivity is not good enough. Most patients who had a low opioid risk score did not have an opioid-related event, but that's true for the population as a whole. It was a very rare finding. So the score really didn't add much to clinical decision-making. So in conclusion, I think St. Max's did well by rejecting this product, and I really don't think other health systems should use it either. So that's my conclusion. What do you think, John, from your sort of healthcare administration systems viewpoint?
I think it's really hard to boil people down to these calculators. And I feel like, just without getting into trouble, I just feel like every time that we kind of release one of these calculators or release a risk score or some sort of EPIC prompt, I think it's a good tool to kind of poke you to kind of remember to think about it, but I don't think it's enough to really make any true decisions by itself. And I often feel like not only that, like one step further, now you're adding something with like stigma. Things like currently going on, like that your patient may have sepsis because they meet SIRS criteria. It's not like that's a stigma where we're not going to treat them. In fact, if anything, we're more likely to treat them. I feel like this is kind of like an anti-treatment stigma, which is very unique for an EMR tool.
Right. And just to be clear, Epic doesn't say that you should withhold opioids from people with a high risk score. It's sort of a screener. But of course, if you're a busy ER doc or seeing a million patients and this big opioid risk score flashes red in front of you, of course it would make you think I shouldn't give this person opioids.
Yeah, and I guess like most of those risk scores and prompts, though, like it's like, hey, you forgot to prescribe a statin in your diabetic. And I'm like, I know, I've talked to him about this for 35 visits. We've talked about it and talked about it. Thank you for that reminder again. This person might have sepsis, start broad spectrum antibiotics. Okay, great. Person has atrial fibrillation. Why are they not an anticoagulant? Those pokes are kind of reminding you to provide treatment. This is like an anti-poke though, right? It's like, hey, maybe don't treat that person's pain with opioids, right? Isn't that what the point of it is? I don't know.
Well,
I think it's...
That's what the point is in a clinical setting. That's what everybody's mind would jump to. Even if there's maybe a different, subtler use, that's not what people will see. So,
yeah.
Who knows?
Okay.
Maybe we'll get it right someday. All right, next article.
Article number 7, or episode 78, medications for alcohol use disorder and severe alcohol-related liver disease. It's from JAMA Network Open from February 2026. The clinical question is, among patients with severe alcohol-related liver disease, does treatment with medications for alcohol use disorder improve long-term survival? Spoiler alert, yes. So in terms of the methods here, medications for alcohol use disorder are incredibly underutilized, right? When you look at the statistics, I believe in this trial, they talked about it was as low as 10% of people nationally receive kind of any medication option for alcohol use disorder treatment. And I think it's because it's not our method under buprenorphine, right? There's no smoking gun. Like you start this medication and it's like, the med does all the work for you right away. So I think because of that, people have some disillusions with it. But this is a retrospective cohort study of 1,309 adults referred for liver transplant evaluation between 2016 and 2022. So this is like the sickest of your sickest liver people, right? So they're going for the transplant center to get on the list. It compared outcomes among patients receiving medications for alcohol use disorder versus no pharmacotherapy. The primary outcome was all-cause mortality. Secondary outcomes included survival by treatment duration and liver transplant status or recipient. The results show that 35.7% of eligible patients received medications for alcohol use disorder despite advanced liver disease. I thought that was incredibly impressive. It's a very high number. So certainly this group is being referred for advanced care and receiving kind of advanced care prior to their referral. Medications for alcohol use disorder for at least 3 months reduced mortality, and the hazard ratio was 0.59. The 1-year survival improved by almost 7, and 3-year survival by 18.5% with medication for alcohol use disorder use in these patients, so the sickest patients. Mortality decreased progressively with longer treatment durations and increasing numbers of medications for alcohol use disorder prescribed. I thought that was very interesting. Greater MAUD exposure was associated with progressively lower mortality. So basically decreasing from 34.7% with no treatment to 12.6% with any MAUD and to 10% among patients receiving 3 or more medications for alcohol use disorder. I thought this was very interesting that treatment effectiveness increased with additional medication exposure. So when you're talking about medications for alcohol use disorder, this is like a case of anti-polypharmacy harms. The number needed to treat for improvement was 31 for 1 MAUD, 12 for 2 MAUDs, and the NNT was 4 for patients on 3 or more medications for alcohol use disorder in terms of effectiveness, in terms of the primary exposure. Patients receiving medications for alcohol use disorder were significantly more likely to undergo liver transplantation, so 39.2% versus 17.2%, with the clear survival benefit of receiving the liver transplant. And the most interesting thing about this at all is I feel like our most effective treatment for alcohol use disorder, or at least the kind of the first line treatment, is naltrexone, right? And so like this is a group of liver patients. I would imagine a large percentage of these patients actually had contraindications to what's considered our most effective treatment for alcohol use disorder. The clinical bottom line is that medications for alcohol use disorder remain underutilized in patients with and without severe alcohol-related liver disease, but particularly among that group. But that regardless of kind of severity of liver disease, even going as far as that they need transplant evaluation, we should be offering these medicines to improve survival. And the biggest thing I took away, not a primary outcome, but don't be shy, don't be stingy with those meds, right? So up to 3 meds were beneficial. And I will be honest, I go 1 to 2. And since this medicine, or since this article, I've kind of gone harder with 3 meds in the paint on some patients.
Yeah, I haven't had the chance to try 3 simultaneous meds on anybody, but after reading this article and talking to you, and then some of our listeners had kind of written in about their experiences, now I'm offering people basically like double coverage if they want medications. I just try to come up with 2, unless they really don't want to, if they just want to try 1. If it's just 1, I often would use like a targeted naltrexone if they really want not a lot of meds, because they can really control the dose. But yeah, I'm trying to lead off with 2 medications simultaneously now. All right, ready for episode 79?
Yep.
We're getting in the home stretch here. So this paper was about direct-to-inject buprenorphine, outpatient initiation of direct-to-inject buprenorphine, published in the Journal of Drug and Alcohol Dependence. And, so we talked about you used to have to do 7 days of buprenorphine prior to starting Sublocade. And now the product labeling has changed to a single dose prior to starting. And now a lot of protocols, and we heard a lot about this at the ASAM conference this year, called direct to inject. You don't do any initial sublingual dose. You just give the shot, just to reduce barriers and reduce time to getting care. So what we know is that fentanyl-involved overdose deaths are common. Buprenorphine is an effective treatment, but only 25% of patients receive buprenorphine who have opioid use disorder. And a big barrier to a lot of patients is fear of precipitated withdrawal, which can be severe and is more unpredictable in this era of fentanyl. Right now, about 11 to 16% of patients who are using fentanyl get precipitated withdrawal. And, this direct-to-inject buprenorphine, people are really afraid of precipitated withdrawal. And so this was a protocol to really evaluate that and see how that would work. There are some of the long-acting buprenorphine formulations that have like a more gradual rise in serum buprenorphine after the first injection, and they peak more at 24 hours. So they hope that gradual rise can kind of help avoid some of this precipitated withdrawal. So this was a retrospective cohort study. It looked at the initiation of long-acting injectable with no prior sublingual doses. They had 131 direct-to-inject initiations in 114 adults, and they were from a wide range of California-based safety net clinics, and they served a very hard-to-reach population. So the patients basically got a weekly long-acting buprenorphine injection, and the dose was at the discretion of the provider, and then a second injection in 24 hours, which could either be monthly or weekly, or at that point they could transition to sublingual buprenorphine. And then they could return every month for subsequent injections. So most patients got a protocol with a weekly injection of 16 or 24 milligrams of bup, followed by a monthly injection, and then medications to treat withdrawal in those first 24 hours. And they looked at treatment retention and withdrawal severity. So this was a really unique data set. This is the first report of 90-day outcomes in a direct-to-inject protocol. Their protocol was totally new, giving a monthly injection 24 hours after a weekly injection. And they did this withdrawal score. They scored it on a subjective patient experience score of withdrawal rather than the standard COWS. So it captured patients' experiences more accurately, but it's a little hard to compare to some other studies. It was retrospective. It wasn't a randomized controlled trial. Patients really could choose the protocol they wanted, opt into this protocol. So since they self-selected, many had prior experience with this protocol, and they may have been self-selected for success. There was also substantial missing data. About 21% of the data points were missing in this study, but still an excellent study. So main outcomes, number 1 is retention and care. 72% continued the buprenorphine beyond their first weekly injection. Most chose a second monthly injection at 24 hours rather than like sublingual or weekly. That was 88%. In 90 days, which was the big outcome, 43% of patients were still engaged in care. At 30 days, 68% were engaged in care. So this is a hard to reach population, and this really did keep them in care. In terms of precipitated withdrawal, which actually was the outcome I was most interested in, so these are people using fentanyl who just got a buprenorphine weekly injection. 37% had no withdrawal at all. 31% had some mild to moderate withdrawal, 11% had severe withdrawal, although 80% of those, even though they had severe withdrawal, returned for their subsequent injection. And 21% were missing data. So even if you assume everyone who was missing data had severe withdrawal, that was still less likely than people who had no withdrawal at all. The clinical utility is that, of this study, it demonstrated this feasibility of this protocol. It was tolerable. Patients liked it and came back to continue the protocol, even if they had severe withdrawal and in a very high-risk population. It's a really viable pathway to starting patients on long-acting buprenorphine treatment, especially for people for whom these traditional initiation methods are not working. In our office, there are some administrative barriers, but in a bigger site with the ability to see patients daily, this protocol would totally be feasible. So what did you think of this study, John?
Yeah, I think it's interesting. I think it's definitely something kind of feasible. It's not kind of quite yet ready for my clinic, but I think we could work through the barriers of this one day, right?
Yeah, it's just the daily. I mean, the problem is I have multiple offices in multiple counties, so I could give a shot one day, but then the next day I might be somewhere else. I just need a big group, or I need a van. I need a mobile van.
That'd be cool.
Get a St. Max's van cling applied.
Something tells me that it might be a requisition request.
I'll just slip it in there along with our flu shot requisition and our need for more gauze pads.
It's awesome. All right, so last one, we'll finish this up. So episode 80, hospital-wide implementation of phenobarbital for alcohol withdrawal. So this is from JAMA Network Open from August of 2025. So the clinical question is, does implementation of a hospital-wide phenobarbital electronic health record order set improve outcomes for hospitalized patients with alcohol withdrawal syndrome? And I think this is something I'm really glad that we covered this article. I think I talked about this probably in ad nauseum at the time that I presented it was, our hospital recently went to we have so many options now for alcohol withdrawal. So we have symptom triggers, fixed dosing, benzos, non-benzos, phenobarbital. It's almost too many options. You're at Chipotle and they add in other items and you just it's too many things to pick from. So, and certainly the ASAM guidelines have now recommended phenobarbital for kind of first line when used by someone with kind of expert knowledge of how to use that appropriately. And a lot of that has to do with a couple of factors of phenobarbital. It's long acting, so you can do a one-time load. It's weight-based dosing that actually has very predictable pharmacokinetics. So it's unlike benzodiazepines, you're not kind of throwing benzos all over the place to try to capture symptoms. And that you can actually use kind of a RAS score as well to kind of titrate, which actually kind of is very appealing as opposed to kind of our very labor intensive and at times variable CWA scoring. So the clinical question, does the implementation of this protocol in this community setting actually make a difference in terms of outcomes, in terms of use of the phenobarbital? And so this was a retrospective quality improvement study of 254 hospitalized adults before and after implementation of a standardized phenobarbital order set. It compared medication exposure, alcohol withdrawal severity, treatment duration, hospital length of stay, and safety outcomes. The results were that the phenobarbital order set adoption reached almost 2/3 after implementation. So I know a lot of docs, right? We kind of hold on to what we're comfortable with, So the fact that 2/3 of docs gave up the blanket here as Linus, it was kind of very reassuring. Benzodiazepine exposure decreased by the equivalent of 22 milligrams of lorazepam per patient. So that's a lot of less lorazepam over a hospital course. Phenobarbital use kind of appropriately increased in terms of utilization. It was using that weight-based fixed dosing. The maxima CWA revised scores were reduced by 4 to 5 points between the 24 and 96 hour mark in patients treated with phenobarbital compared to benzodiazepines. Alcohol withdrawal treatment duration decreased by approximately 30 hours, and hospital discharge occurred 2.2 days earlier when using phenobarbital in lieu of benzodiazepine for alcohol withdrawal. Rates of intubation, prolonged restraints, and hospital mortality remained unchanged, demonstrating really no safety concerns between the two protocols. So the clinical bottom line here is that at least in this kind of retrospective quality improvement study, also kind of consistent with kind of recent updates and guidelines, phenobarbital, it seems to kind of reign supreme here, right? It seems to have it's better for everyone, right? So kind of patients seem to capture quicker, patients have lower withdrawal severity, patients are in the hospital shorter durations of time. That's good for the hospital as well, because kind of prolonged hospitalization, especially in kind of patients with alcohol withdrawal, tends to actually be kind of a cost loser at an organizational level. So I mean, this truly was a practice-changing article for me. And like, I've kind of like left my benzos behind for this, and I'm going full steam here. And I actually haven't used a benzo in the hospital. I do work in the hospital as well. Haven't used it.
Nice. Yeah. And next stop, outpatient alcohol withdrawal, right?
Yeah.
Totally. Oh my God. Well, we made it in under an hour. So thank you everyone for listening to the Addiction Medicine Journal Club. We really want to hear your thoughts because the best part of any journal club is the conversation. If you have a favorite article or have any opinions about what we've said here tonight, please send us your comments on social media, email. You can join our Facebook group. The links are in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, produced by Dr. Patrick Beeman and Arslandra Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we reviewed. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.